So let's go now to so I already explained the concept. The concept is the same with DVT because it can start as a DVT and then end up with a PE, but it doesn't have to. Patient may bypass having a DVT and then go straight to a PE. We already discussed the varicose triad, the 3 ways we form blood clots. So there are 3 sets of risk factors for these patients. Somebody, Miss Lam earlier approached me that the other risk factors, which are listed on the risk factors. So prolonged sitting falls under venous stasis, right? And then for oral contraceptive pills and obesity, that falls under hypercoagulability. Okay, all again, part of the varicose triad. And if you add smoking there, then that will also be another hypercoagulable condition. So here we are, PE. So this is the most common cause of death when you find a patient dead on the unit. Let's say you work on a med-surg floor, you haven't made rounds on your patient. The patient was just found dead. I'd bet 8 times out of 10 that patient had a PE, just died suddenly. Okay, so they couldn't call out for help because if it's a massive PE, they just gasp their chest because they can't breathe, oxygen drops, and then they can't even shout for help, and then they'll just die a very painful death. It'll be quick though. That's why I really don't like working on a med-surg floor, because I'd like to know if my patients are alive. So if you're there on telemetry, you know someone's watching the monitor, they have a rhythm, they're alive. Okay. So I won't repeat the varicose triad. We discussed that last week. Now let's go to the diagnostic testing. So it takes a skilled radiologist in order to recognize a PE, because remember I said there are 3 categories. There's a low risk, there's a submassive, and then there's a massive PE. So for low risk and submassive, they're not very easy to identify. Plus the patients under those 2 categories don't always present with the usual signs and symptoms, which we'll look at next. Plus there's complications or contraindications to the test. The gold standard is to do a contrast CT. So you have to use an IV contrast in order and do the pulmonary angiogram in order to see the blood clot. Okay, and you can't do that without dye. Then there's always, of course, because these people who are sick who get this, okay, that means they have 1 or more of the varicose triad, right? So that includes immobility, meaning they're sick to begin with. They're bedbound, so therefore they got the PE. So therefore, will they also have some kidney injury? Yeah, so that's possible. So is that a contraindication for the contrast dye? So they can't do the testing, but they have to do it. So the only other option is to do a BQ scan. So it's called a ventilation perfusion scan. It's also under radiology, but under nuclear medicine. So this one uses a radioactive dye. So if we can't give a contrast agent intravenously for fear of damaging the kidneys, we will have to give the patient gas, a radioactive gas to inhale, and then we'll scan the lungs. So instead of going through the vascular system, we'll go through the pulmonary system. So whichever section of the lungs, when they inhale the dye, and whichever branch of the pulmonary artery did not absorb the dye, there's the blood clot. Make sense? Okay, so we'll go the other way. Much more expensive, but and plus not all hospitals have this test. They only, bigger hospitals have nuclear medicine. So the problem with PE, especially the massive type, is what happens if 1 or more branches of the pulmonary arteries are blocked? So what happens to forward circulation? Because which part of the heart pumps blood to the pulmonary circulation?
The right ventricle.
The right side, right? So the right ventricle pumps blood to the pulmonary arteries. What if they're blocked and there's multiple of them? So what's going to happen to forward blood flow? It's gonna drop. So what happens to blood returning to the left side? So therefore, what happens to cardiac output? Okay, so what type of shock do we have here? Hypovolemic, cardiogenic, obstructive, or distributive? This is a form of obstructive shock. So same effect as cardiac tamponade, same effect as yeah. So there's obstruction here. So patient can literally die from shock. Okay, with the massive PE. Manifestations, although we have a list here, not all patients will present the same way. So doctors will do it clinically. Just put 2 and 2 together, consider how many, will do they'll do a scoring of the patient's risk for blood clot formation. They'll count how many of the varicose triad they have, and then the higher the score, you only need 2 points, by the way, in order to be at risk. So if they score 2 or more, so the higher, then the more likely the patient will have a PE. So dyspnea, although it says here frequent, some patients may not have it. Some patients with low risk PE may just say, I don't feel good. Like, I know something's wrong. They have that sense of impending doom. That's the only symptom they'll have. Then they'll come to the ER because of that. Of course, we don't say, are you just paranoid? Okay, we run tests because sense of impending doom is a common manifestation of PE. So besides signs and symptoms of hypoxia, the severity will vary depending on whether it's low risk, submassive, or massive PE. The size and number of the emboli involved. Chest pain is common. So they'll resemble any acute coronary syndrome patient. So when these patients come in, we consider acute coronary syndrome or PE. So we run all those tests. So we draw blood, usual troponins, BNP, chemistry, hematology, and we add to distinguish whether it's PE or not. We add what blood tests supports the evidence of a blood clot? D-dimer. So they'll add D-dimer. In addition to the usual, workup for acute coronary syndrome, and then they'll have the D-dimer. So if it's elevated, then pointing towards a DVT or PE, then they'll send the patient for a CAT scan. And other symptoms of course, these are associated with decreased cardiac output, okay, and sympathetic stimulation as well. Because when oxygen drops, what is always stimulated? Sympathetic response, okay? Fight or flight, epinephrine is stimulated, and then as well as the renin-angiotensin-aldosterone system. So like I said, PE may not always have the classic symptoms mentioned in the previous paragraph. Okay? Some of it may have none or very little or resemble other conditions. I already mentioned the testing. So your responsibility here is to check chemistry, help out the doctor, whether it's safe to send the patient for the CAT scan with contrast. I already mentioned if there is evidence of kidney injury, what test is the alternate? Okay, VQ. Why it's called VQ and not VP? Because the test really is called ventilation perfusion scan, meaning they're doing the ratio. Is there equal? Is there 1-to-1 ratio between ventilation and perfusion? If not, then the term here is really ventilation quotient. Because when you divide something, that's the quotient, right? Yeah. So mainstay is anticoagulation, except of course if it's massive PE. So we discussed last week anticoagulation, various anticoagulant choices from heparin to warfarin to low molecular weight heparin to the novel oral anticoagulants like your 10A inhibitors. So all of those place the patient at risk for bleeding. So review again your interventions how to care for a patient at risk for bleeding. And of course, each one, depending on the drug use, each one has a specific monitoring lab to be monitored. So what again is for heparin? PTT. Okay, what about for warfarin? Okay, remember last week we talked about dosing. So what's the basis for the dose for unfractionated heparin? Why do we check PTT every 6 hours? It's based on the PTT. Okay, so the dosing for heparin, unfractionated heparin, is the PTT. So remember I asked you last week, if the PTT is low, what do we do with the dose? Increase it. PTT is too high, decrease it. PTT is therapeutic, leave it alone. Okay. And what is the basis again for low molecular weight heparin? What's the basis for the dose? The weight. Okay, so when I asked last week, is there a need to change or to monitor the PTT? No, because the basis for the dose is the weight. Unless the patient loses or gains 20 pounds or something, then that's the only time we change the dose. So for massive PE, patient again is hemodynamically unstable. They go into cardiac arrest, severe pulmonary hypertension results. Patient goes into right side heart failure with cardiogenic shock. So that's why it's obstructive shock. So the treatment there will include thrombolytic therapy. Same TPA, same alteplase we use for the stroke patient. And of course, CPR and then full ACLS. Well, ABC, always ABC. So the patient is revived first because they are in cardiac arrest. So we do ACLS, and then to address the underlying condition that led to the cardiac arrest is thrombolytic therapy. Depending again, if it's there's no way to know if it's low risk, submassive, or massive. We need a CAT scan. There's no CAT scan on the plane, so it happens on a airplane. We do what we can. I mean, you're up the creek, basically.
Interventions that it's non-medical intervention.
What can we do? I mean, unless somebody's carrying out around a thrombolytic or anticoagulant, yes.
At what point can the patient be intubated?
Definitely if it's massive PE, when they go into cardiac arrest, so they're intubated automatically.
Like, how would you differentiate between? When I first started flying around my phone, I started having anxiety. I was having like, how can you differentiate between that and having anxiety and
there's no way to know. Even doctors can't tell unless we do a test, and then if it's really PE. Because some, anxiety can have that sense, feeling, all the time. So if the clot involved is really huge, so an alteplase cannot dissolve that, it's too big, then it'll be surgically removed. So a vascular surgeon will be consulted, and then they'll take it out. For which one? Massive PE, I mean, no, it's not much, because you go into cardiac arrest. So depends what the scenario is. So let's say if it's in her example, it happens on a flight, you're dead. For people who cannot, there's a contraindication for anticoagulants, meaning they had a PE and then high risk for another one, meaning after evaluation, the patient has too many risk factors, meaning the score is so high, 2 or more. then the patient usually is placed on anticoagulants, right? Usually for life after one episode of a PE. So people who are high risk, let's say dementia patient, really old, 80 years old, high risk for bleeding. This is an option. We'll put in a IVC filter. It looks like a umbrella without the cloth, okay? So it's like the sticks, okay, right here. So it looks like the no, the yeah, metal parts of the umbrella. So they'll put this in the inferior vena cava, and what it does is just catch blood clots coming from the lower parts of the body, from the GI tract, coming up, because that's where usually blood clots come from, right? It's 90% effective. Why not 100? Because what if the blood clot forms above the neck? So it comes from your arms, so it can't catch it. There's no such thing as a superior vena cava filter. I mean, they can't put one like that. So they can only put a IVC filter. But I'll take the 98%, wouldn't you?
How many percent? 98?
98.
Yes, I knew someone.
But of course, these things can fail. They can break, they can cause obstruction, they can cause sepsis. But again, 98% effective.
So if you catch a clot, will you talk to?
Remember last week when I showed you the video? So what does the body do after a clot is formed? Not sometimes. Always, it's going to be dissolved by the body. However, depending on the size and number, it will take time. So as long as it's there, you have so it will be dissolved eventually. So that's why we only give anticoagulants for the other types of PE, not a thrombolytics, because what do we need to do? Just what do anticoagulants do? Stabilize the clot, meaning will the patient make any more? No. Will the existing clot get any bigger? No, because you interrupted the clotting cascade. So it stays the same size and no more new clots will form. Of course, if that's a condition, the patient is at risk for bleeding. Okay, that's why we teach them to avoid instances of increase or possibility of bleeding. Greenfield filter is the most commonly used brand of IVC filter. They're the first, that's why it's mentioned here. Oh yeah, it does say original. So yeah, that was the first IVC filter. There are many brands now, but people still use Greenfield. So again, the management really depends on the severity of the PE. So if it's low risk and submassive, anticoagulation will suffice. If the patient has massive PE, these patients are again not stable. They could go into cardiac arrest, so they are given thrombolytics. Oh, we have a picture here of the IVC filter. And these are the same anticoagulants we used last week. Why again is the patient on, let's say, submassive PE? Why is the patient placed on both heparin and warfarin? Correct. So, because does warfarin have immediate effects?
No.
It takes days, right? So therefore, we use heparin because does heparin have fast onset? Yes, the moment it infuses in the vein, anticoagulation begins right away. Okay, we already said this repeatedly. So if patients are hemodynamically stable, it's always just anticoagulants. As to the choice of what anticoagulant to use, again, our only responsibility is to specific to what is ordered by the doctor. Nurses are not the ones deciding which one to place the patient on. So our job is to teach the patient based on what anticoagulant are they on. So what are the restrictions again for heparin? Is there any diet restrictions?
Yes. Rainy.
Heparin?
No, only
Oh,
for
that's
the-
what I'm
Okay. Warfarin has the diet restrictions. None. There's none for heparin, none for the DOACs also, 10A inhibitors, none. Okay. And DOACs also have no blood monitoring either. Okay, there's none. Sorry. For heparin, yeah.
Yeah.
Okay, I won't repeat this. The patient with stroke received
Yeah.
alteplase, so we know how to care for those patients. Pain management, patients are given opioids, the pain and PE at least. Oxygen, we titrate whatever's needed in order to achieve 95% or better. It is anxiety provoking. The patient could die from this condition, so we give them benzodiazepines if needed. And of course, complications are cardiovascular in nature, including shock. That's about it for PE. And this is your teaching. Again, this is a repeat of the prevention we already did last week under DBT. Okay, same exact teaching. Questions?